Hi, everyone, and thank you for joining the Georgia Recovers August webinar titled Substance Use and Stigma, Prenatal Substance Use and Adapting Interventions for Women. My name is Jalen. I'll be your host for this afternoon. Feel free to drop your name and organization in the chat box so we know who all is joining us this afternoon. So for our agenda today, we will cover welcome and housekeeping. I'll provide a brief overview of the Georgia Recovers campaign. I'll introduce our speaker who will then present for the bulk of our hour today, and then we'll wrap up with a Q&A. So regarding housekeeping, this webinar will be recorded and a copy of the presentation will be available on the Georgia Recovers website. All attendees will be muted throughout the duration of the webinar as well. And use the Q&A panel on the bottom of your screen to ask any questions. The chat is available for general commentary, but it won't be moderated as closely. So please use the Q&A panel if any questions arise for you. Our interpreter, Sarita, will also be spotlighted throughout the webinar. To adjust your view and see all of the speakers, click view on the top right corner of your screen and then select speaker or gallery. Users can also select a side-by-side view. And then also you can access the transcription of the webinar via our stream text link, which Ashley will drop in the chat box. And on to our Georgia Recovers overview. So Georgia Recovers is an evidence-based public health campaign that is aimed to reduce the prejudice and discrimination that's associated with substance use disorder in Georgia. This campaign is powered by the BHDD and builds off of the pivotal work of Georgia Council for Recovery. So we have a few goals and objectives, including increasing knowledge around substance use disorder and that recovery is not only possible, but probable. We also seek to improve attitudes towards those living with and are in recovery from substance use disorder and strengthen the capacity of stakeholders, including organizations and individuals that are already responding to the crisis. So we have 3 pillars of work, including community connection, story sharing, and education. So under our community connection umbrella, we connect with different organizations across the state of Georgia. We also have our advisory committee, aka our CIC, that help to guide the direction of the campaign. Story sharing is also really central to the work that we do. So we collect stories of recovery and allyship, and those stories are shared across our social media channels. We also change attitudes by promoting messaging that speaks to hope and recovery. We also host these bi-monthly webinars that shed light on topics that are related to substance use disorder. If you or anyone you know may be interested in sharing their story with Georgia Recovers, Ashley is going to drop a link in the chat so we can get started with our story collection process. If you've watched or kind of tuned into our story library at all, you know how inspiring and moving these stories can be. Also connect with us on our social media platforms. So at Georgia Recovers on Instagram and Facebook. Also, if you're interested in becoming an official campaign partner, Ashley is going to include that link to our partner form in the chat. Takes about 5 seconds, just collecting some demographic information, and then we'll be good to go. And on to our speaker for today. So Dr. Callio Honeycutt Ferguson is an assistant professor at Emory University School of Medicine, Department of Psychiatry and Behavioral Sciences, and a prevention specialist with Emory Center for Maternal Substance Abuse and Child Development. She completed her PhD in clinical psychology at Northwestern University's Feinberg School of Medicine, internship at the New Jersey VA healthcare system, and a postdoctoral fellowship at Weill Cornell Medicine. Dr. Honeycutt is actively involved in research and prevention efforts focused on substance use disorders and their impact on women's health. She is also a licensed clinical psychologist with expertise in providing evidence-based psychotherapies, including cognitive behavioral therapy, motivational enhancement therapies to adults with substance use disorders, in addition to co-occurring mood, anxiety, trauma, and related disorders. She is passionate about teaching and has leadership and education roles in psychology and resident training at Emory. So thank you so much for joining us today, Dr. Honeycutt. I'm going to stop sharing my screen and then pass it on to you.
All right. Thank you so much, Jayla. It's great to be here. All right, I am sharing my screen. Yeah, so thank you so much for the introduction. I won't go into any more detail about my background, but I know we're gonna have the Q&A for any questions, and we'll also save some time at the end for questions as well. And we have a lot of material to get through today, so I'm just gonna kind of jump right in. So as always, I need to and want to acknowledge funding sources, and I do not have any conflicts of interest to report. And just like to, I am, as Jayla mentioned, I'm a licensed clinical psychologist, and I'm also a prevention specialist with the Emory Center for Maternal Substance Abuse and Child Development. So I'd like to just provide a brief overview of our services as is relevant to this presentation. And so our center is under the direction of Dr. Claire Coles, has really been active since 1980 and has focused on the effects of prenatal exposure to alcohol and drugs, both legal and prescription. And we have a few different arms. We have developmental research and brain imaging, the prevention arm, which is really what I'm a big part of, and then our treatment and research arm, where we actually provide intervention, assessment and intervention services for children and families that are affected by prenatal substance use. And so today we're going to be talking about a lot. So I'll try to get through and try to, as I mentioned, leave time at the end for questions. I will hope by the end of today's presentation that you will be able to describe the stigma related to substance use disorders, as well as the unique ways that stigma comes up for women and pregnant women with substance use problems. I will hope that you all will be able to name the most commonly used substances by women and during pregnancy and their impact on child development. And then the final part of the presentation, I will review interventions for substance use disorders and what we know and also don't know about adaptations that are needed to address the unique needs of women and pregnant women with substance use disorders. So I always like to start with some definitions. You all may or may not be familiar with these already, but we know that the majority of the population does use some kind of addictive substance, even if it's only caffeine. And so we think of substance use disorders on a continuum. That ranges from no use to moderate or mild use to problematic substance use. And so when we are looking out for substance use that's becoming a problem, we might look for things like somebody who's repeatedly tried to stop using the substance and been unsuccessful, someone whose tolerance has increased over time for a substance, they're needing more and more of the substance to get the same effect, someone who may have withdrawal symptoms when they stop using the substance. And it could also include things like engaging in high risk behaviors when using the substance, or just more generally having problems resulting from the substance, like interpersonal problems or problems functioning at work and continuing to use the substance despite those problems. And though the field has made some progress over the years with stigma, there is still, unfortunately, stigma associated with substance use problems. And there are some people who still think that these problems, people should just be able to handle them on their own, that willpower should be enough, or that having problems with the substance is a moral failing. But actually, we know that substance use disorders are a chronic brain disorder. and at the same time are treatable medical conditions. Along the lines of stigma, there are some terminology that we kind of lean away from in efforts to reduce stigma. So the term addiction was actually removed from psychiatry's diagnostic system because of a number of reasons. It had kind of an uncertain definition, but also potentially negative connotations associated with it. Similarly, that we no longer actually use the term substance abuse or substance dependence. There's kind of an implication with some of these terms that with abuse, that it's a person's choice that they're engaging in this behavior. We also try and stay away from labels such as addict. Also negative terms like labeling someone who is using as being dirty, and somebody who's not using as being clean. And then recovery can have some stigma in that I think there can, because of the stigma associated with substance use disorders, certain people may be hesitant to label themselves as being in recovery. And so some additional important points about stigma. We know that there have been surveys that have been done about individuals with substance use disorders, and it's been found that individuals with SUDs are more likely to be perceived as low in warmth and competence, as dangerous or unpredictable, as responsible for their condition, as I mentioned. And that individuals in the US have reported in these surveys a low willingness to have a person with an SUD be part of their communities, whether that's marrying into their family, working with them, or being friends with them. And we know that in actuality, individuals with SUDs are people just like anyone else. And that, again, this is a chronic medical condition, just like many others. And so we see that through these survey responses that there really is still a lot of stigma. We've got a lot of room to grow in this area. And why is this a problem? So stigma leads to health inequities. So because or when people are viewed that their behavior is a choice or voluntary, often there's a lot of shame associated with that, that then can get in the way of seeking treatment or even disclosing that they have a problem. So this is a really important area that needs to be worked on, and that we're all, I think, through education like this, are working on reducing that stigma. So in addition to stigma more generally with substance use disorders, there's arguably even greater stigma for women with a substance use disorder and mothers who struggle with substance use problems. And so it's important to therefore understand some of the unique ways that women are impacted by substance use. So we know that women are kind of harder hit by substance use problems than men, in that there is something called a telescoping effect, where although women tend to initially use substances at lower levels compared to men, they have a more rapid escalation to having a problem with that substance, and have certain physiological effects that are more severe and health effects. So, for example, women have a higher blood alcohol concentration with the same amount of alcohol compared to men. And that's part of the reason that some of the recommendations for alcohol, kind of maximum alcohol use, are lower for women compared to men. There are also increased risk of certain types of cancers for women, fertility issues, greater risk of liver disease, heart damage, and increased risk of mortality for women with substance use problems. And women with substance use problems, to the second bullet point here, have some unique stigma-related challenges and barriers to getting treatment. So though 1 in 3 people with an SUD is a woman, only 1 in 5 people in treatment for an SUD is a woman. And so there's this gap in who is actually accessing care. And for pregnant women with an SUD, there are also frequently scrutiny from healthcare providers and from society more generally, and can include assumptions that substance use during pregnancy represents child abuse. This is reflected, the stigma is reflected in some policies in certain states that criminalize women for using substances during pregnancy. And often policies are applied inequitably, with Black women and women of color often being more likely to be tested for substances and reported to child protection, compared to white women. So we know that rather than criminalizing substance use behavior, women who are pregnant need priority access to treatment for substance use disorders, as has been implemented in some states. And so there's a number of challenges. So we've already talked about stigma, but there's a number of other potential barriers for women in getting access to care. Um, so much of the philosophy of treatment in substance use disorder programs is based on a male model of treatment. And some of these methods may either be inappropriate for women or not take into account the unique considerations that women might need. Um, so one example of this is that women who are using substances often experience co-occurring mental health conditions that need to be addressed. And treatment, there are some treatment facilities that may not be comfortable with what's sometimes called dual diagnosis, or a substance use disorder and a co-occurring mental health condition. There often are unique psychosocial issues and trauma that women have experienced that need to be addressed, that again, a facility may or may not be prepared to do. There are practical concerns. So if it's a pregnant woman, if she, or a woman who's not pregnant but who has children at home, there can be issues with childcare, transportation, support or lack of support from partners, the cost of treatment, of course, and limited resources. And then pregnancy specifically, there are even fewer programs for substance use disorders that are dedicated specifically for women with who are pregnant. So from a prevention standpoint, we know it's important to provide as much as we know works, and often for women, having being able to address some of these practical concerns. So for example, providing support for childcare if it's a residential program, or helping with kind of connecting to work after the program, all are important, as well as accessing medical care or prenatal care if the woman is pregnant. And I think I saw something in the chat. Okay. I don't think there was a question. If I miss anything though, would someone shout it out, please? I'll try to keep an eye on it. Okay, so we've set the stage for stigma of women's substance use and some of the challenges to getting care. And so I'll now talk about some of the trends in substance use, rates of use in pregnancy, and then conclude by talking about some of the interventions that we have available. So some of the changing trends that we've seen, in the past, men were more likely to report use of alcohol and drugs, and that's part of why probably a lot of the treatment programs are based on a male model, but rates among women are rapidly approaching those of men. And actually among certain age groups like teens, there are no differences, gender differences. Men still do report overall higher use of alcohol, tobacco, and most illicit drugs, but women and men do report the same levels of opioid misuse. And so this diagram is from SAMHSA's National Survey on Drug Use and Health. And so we see that this is past year substance use among women in the 12 and older is just the range that people, or that is part of this survey. But we see that It is legal drugs that are most commonly used. So alcohol really stands out here, as well as tobacco products. And then in some states, marijuana is legal, and that's obviously changing rapidly. And so we'll look at this more specifically. So for alcohol use among women 12 and older, about 60% of women report using alcohol in the last year, with past month use being slightly lower, around 50 to 55%. And we see similar rates of alcohol use across women of childbearing age. And in looking at trends across the past few years, these rates have generally remained fairly stable. But when we look at some of if we go back to the continuum of substance use, it's important to look at substance use that may be more problematic. So, for example, binge alcohol use. And we see that among women who do report alcohol use, about 40% report engaging in an alcohol binge, which is 4 or more drinks in a sitting. And they report doing that at least one time in the past, in a 1 month period. And then the red center in the circle, they're in a fewer number, but still fairly substantial, about 23% that, about 23% of binge alcohol users, of those, about 10% are reporting being a heavy user, which is binge drinking on 5 or more days per month. And when we think about, again, kind of risk reduction, we're going to be targeting, or we want to target, kind of reduction of binge use. And when we think about prenatal exposures, that's another important target, because we know that about 50% of women of pregnancies are unplanned. And so for women of childbearing age who may be binge drinking, they could have an unintentional exposure. In terms of tobacco use, we see about 20% of women reporting past year tobacco use. This includes all types of tobacco products, so cigarettes, e-cigarettes, nicotine vapes. And we know that there is some variation in by age group in who's using what type of tobacco product. Though really there's not actually any safe way to ingest tobacco products. But I think there's a perception that vaping is safer, but we know that's not the case. But you can see that among individuals 12 to 17, a vast majority are vaping, as compared to in the 26 and older age group, there's more of many more are using kind of traditional cigarettes. And I see the question about why do men report it more than women. So I think there are a number of reasons, but I think one of the reasons is that there was traditionally less stigma associated for men who were reporting use. And so it was not sort of looked down upon as much to report substance use. And I think there's also, we know that mental health conditions are commonly co-occurring for anyone with a substance use disorder, not just women, and that for probably reasons of stigma and kind of socialization, that for some men who are using substances and have a mental health condition, they may feel more comfortable reporting substance use as compared to reporting that they're feeling anxious or depressed. So looking at marijuana use, about 17% of women are reporting past year use, and this is definitely on the rise, as marijuana has become decriminalized and its legality has changed across the United States. This graph, the highlighted portion is showing past year marijuana use. So we see that it's young adults age 18 to 25 are using about twice as much as about twice as many women in this age group report use compared to women in the other age groups. So that 18 to 25 age group is an important prevention target. And I'll just briefly speak to this. So many people are probably aware of marijuana's increasing availability and legality. And some of the concerns that related to this decriminalization and legalization are that the THC concentration levels in marijuana have increased quite a bit over the past 25 years. And so this says 3 times, but there are some strains where it's even probably more than that. And THC is the psychoactive substance in marijuana. And so there are concerns that marijuana itself, as it is still an addictive substance, even though sometimes it's perceived as safer. Actually, about 1 in 10 people who use marijuana regularly will develop a marijuana or cannabis use disorder. And that's even higher if the individual starts to use in their teens. And there's just a much greater variety of products, and some that can even be purchased now, such as Delta-8 products in gas stations or smoke shops. And so it's just becoming a lot more available, and because the THC is higher concentrated, we may start to see trends in increases in substance use problems related to marijuana. We also know that its use is on the rise among all groups, but that also includes pregnant women. In terms of stimulant use rates, we see lower rates of the substances that are kind of overall illicit substances in the US. So methamphetamines and cocaine fall into this category. About 1% of women are reporting cocaine use, and 0.7% reporting methamphetamine use. But this will take a look in a moment at age differences, and there are some trends there. But cocaine and methamphetamine are 2 substances that are looked at in that National Survey on Drug Use and Health, but stimulants actually include a range of drugs, both legal and illegal. So it does include prescribed medications like Ritalin, Adderall, but also caffeine is also a stimulant. And we know that stimulants affect dopamine reward systems, which can cause a cascading release of dopamine and lead to pretty quick development of problems with the substance. So when we look at age differences, we're seeing this trend in kind of increasing methamphetamine use in women age 26 and older in recent years. And we see with cocaine that it is used by far most frequently in women aged 18 to 25. So that's the center orange bar. And then finally, we'll talk about opioid use. So that includes both heroin as well as prescription opioids such as oxycodone, fentanyl. And we know that about 3.5% of women are reporting past year use of some form of opioid. And we also know that women are disproportionately affected by opiate misuse because of increased prescription to women of opioids. We know that younger women in the 25 to 54 age range are more likely to present at the ER complaining of chronic pain compared to older women. And we know that women are now reporting heroin at rates comparable to men. Though still, again, the rates are fairly low, but the risk with heroin is that there are high overdose, and especially with fentanyl and other products being mixed into both street street prescription medications, but also heroin, that there just are a lot of risks. So we see that since 1999, there's been a 400% increase in opiate overdose deaths in women. There's still a high rate in men, and that it has increased, but you see it's quite a bit higher than in women. And in this survey that was done in 2021, hydrocodone products were the most commonly misused subtype of prescription pain relievers, but you'll see the variety of different types listed here. I would guess more recently, there's probably higher rates of maybe not prescribed fentanyl, but that fentanyl is going to be showing up more in drug tests. And when we're looking at the various forms of prescription pain reliever use in the past year, again, we're seeing hydrocodone products being used most frequently compared to heroin. So in summary, when we're looking at and thinking about rates of substance use in women, women generally use substances at lower rates, with the exception of opioids. Alcohol and tobacco, though, are still the substances used most commonly by women, with marijuana being second or third, I guess. Women in the 18 to 25 age group use all substances at the highest rates. Except for the trend for methamphetamine that I showed earlier. When women are disproportionately affected by opiate misuse via prescription medication and are prescribed opiates at higher rates compared to men, and prescription opiates are responsible for by far the highest rates of overdoses and deaths in the US. So I might pause there and see if anyone has questions about anything I've covered so far. All right, so I'll briefly touch on some of the unique issues and rates of substance use for pregnant women, and then we'll conclude by talking about interventions. So there's a number of reasons why I think sometimes, again, related to stigma, people question, are we assuming that most people know that using drugs or alcohol during pregnancy is not what you should be doing? But that's not necessarily the case. And there are a number of reasons why this might happen. So, as I mentioned before, about 50% of pregnancies are unplanned. And so the person may not be aware that they're pregnant. They may not be aware of the severity of damage that substances can cause. There are frequently these normative comparisons. So I know this other person who drank throughout their pregnancy and their kids turned out just fine. There may be normative substance use within the social group or family. So it's very common for women that have a substance use problem to have a partner who also has a problem. Or it could just be that within their family, it's been high rates of substance use has been normalized. They may be using substances to cope with difficult life situations. Again, they may have a substance use disorder, meaning it's going to be hard for them to just stop cold turkey, even if they have a very good reason. They may fear the consequences of disclosing use, so that may prevent them from getting the help that they need. And physicians may not ask or know how to help if the person does endorse use. And a pregnancy is an incentive to quit, but it also can be added stress and a fairly short time to change behavior, social life, and relationships. So on the one hand, so this graph shows rates of substance use nationally for women who are pregnant and then not women who are not pregnant. So the green is women who are not pregnant. So the good news is we see there is a significant difference for rates of substances reported used during pregnancy compared to when women are not pregnant. And So, and notably a lot less binge drinking. So you can see about 26.8% of women report a binge alcohol use, whereas only about 5% of those who are pregnant report that. Um, so, and we also know that in women who are intending pregnancy, they are about 30% less likely to drink alcohol. So the issue comes with, as I've mentioned several times, that a substantial number of pregnancies are unplanned, so there may be unintentional exposures. And when we think about specific high-risk groups, so for example, teens and young adults, we know that about half of US adolescents will be sexually active by the age of 18, and of these, more than half report having used alcohol or other substances during their last sexual encounter, which can then, of course, reflect or affect unprotected, increased likelihood of unprotected sex or use of compliant use of birth control. Um, again, we're seeing the highest rates of substance use of legal substances, alcohol, cigarettes, and then a similar number using marijuana compared to cigarettes. And then smaller percentages of other drugs like opioids, cocaine, hallucinogens. But the other thing we know is that these are likely all underestimates of use. Underestimating or underreporting use of substances is common across the board, but certainly for individuals where stigma is higher, it's going to be even more common. So again, legal drugs are the most commonly used, followed by marijuana and prescription drugs. Cocaine, methamphetamines are next, and then opiates like heroin and other prescription opiates are the least reported. However, I think what's really more the norm is that if someone is using one substance, they are likely to be using multiple substances. And we know with marijuana in particular, it is very frequently accompanied by the use of other substances. So about 50% of women who are pregnant who are reporting marijuana use also report smoking more than 10 cigarettes a day. About 12% are currently using opioids. About 10% report using stimulants, and about 4% of those have an alcohol-related diagnosis, so an alcohol use disorder during pregnancy. So if you are a provider or someone who works with pregnant women, if you hear that they are reporting marijuana use, you want to be kind of attuned to asking about whether they might be using other substances as well. So I'm realizing this may be a little bit small to be able to read, so I'll try and read out. We know we have quite a bit of understanding of the effects of different substances when they are used during pregnancy. So tobacco and nicotine has some negative short-term and long-term consequences. So it increases in the short-term risk of stillbirth and breathing issues. The babies that are born have an increased risk of SIDS, as well as long-term increased risk of auditory perception, difficulties, language development, and conduct disorders. With marijuana, there haven't been any consistent short or long-term effects found. And consistent is underlined here because the problem that has come up with a lot of the data is that the research that's been done, the individuals who've been included have often been, in addition to marijuana, been using multiple substances. So there hasn't been a way to kind of parse out yet, or we haven't found any effects specifically of marijuana. The studies that have shown effects, the women were also using stimulants like cocaine or alcohol. And so that's not to say that we recommend women use marijuana during pregnancy. It's more to say that right now we don't know. And I think another piece that's important here is that going back to the increased concentrations of THC over the years, we don't yet have data on whether that increased concentration of THC might have some unique effects. Alcohol is one of the most teratogenic substances when used during pregnancy. It causes global cognitive deficits, facial dysmorphia, specific neurodevelopmental impacts, and academic deficits, among other problems. The main effect of opiates is neonatal opioid withdrawal syndrome, or what you may have heard called NAS, or neonatal abstinence syndrome. So it actually doesn't seem that opiates have prolonged long-term negative effects. It's more in that if the parent is using opiates right up until the birth, the baby is going to go through withdrawal symptoms when they are born. And so that can be medically managed. But once the opiates are out of the baby's system, don't seem to be any other effects. And then finally, stimulants, including cocaine, have quite a few negative effects as well. So miscarriage, increased risk of stillbirth, preterm birth, and growth retardation. And long-term, there are arousal regulation difficulties. It affects emotional development and executive functioning, so cognitive abilities. All right, so the final portion, I'm going to talk about interventions for women and pregnant women with substance use disorders. So first, I'll just briefly cover, these are the evidence-based interventions for substance use disorders. This is not specific to women. There are quite a few medications that are FDA approved for substance use disorders, specifically for nicotine, alcohol, and opioid use disorders. And SAMHSA's website has a great treatment locator for accessing providers who can prescribe these kinds of medications. There are psychotherapies that are evidence-based for substance use disorders, including cognitive behavioral therapy, motivational interviewing, and community reinforcement approaches. And then adjunct supports are often very helpful. So things like community support groups like 12-step, AA and NA, or Smart Recovery, which is more of a skills-focused community support group. And then often family and couples therapy is very helpful, getting the involvement of the person's family to help support recovery. I mentioned before the importance or the how common it is that mental health conditions co-occur with substance use disorders. This slide just covers what is common during pregnancy and postpartum, but this would be, of course, important to address as part of treatment. So we know that mood and anxiety disorders co-occur in about 50 to 80% of mothers or birth givers during pregnancy or postpartum. And can last up to 2 years postpartum. Baby blues are experienced by almost the vast majority of women. Depression in about 20%, anxiety in 6 to 8%, obsessive compulsive disorder in about 4%, PTSD in about 2 to 9%, and psychosis in about 1 to 2%. And so when we're looking at adaptations of evidence-based therapy for women and pregnant women, so there are a number of adaptations that have been recommended. And unfortunately, while there are those evidence-based treatments that I mentioned before for substance use disorders, much of the research really has focused on men or has not taken into account the unique needs of women. There may be more, but in my recent search, there is one treatment that has been adapted for women with substance use disorders. So I have the manual screenshotted here, the Women's Recovery Group. And so there really has not been a lot that has been done. I think for those of us who work clinically in the field, we're really just trying to understand each individual woman on an individual basis and try and make sure to treat the co-occurring disorders in addition to the substance use disorder. But again, there are some recommendations for what is helpful. So for women, it is recommended that there's collaborative case management. Again, the need for treatment of co-occurring mental health conditions, and then understanding the unique needs related to the use of specific substances. So there's a lot that we don't know necessarily about kind of how do we treat a woman with a cocaine use disorder compared to how we might treat a man with a cocaine use disorder. We just don't have that information, or whether we treat those differently. But again, we do know that for women, there often are these kind of wraparound services that are going to be helpful, and then even more so for pregnant women. So hopefully you can see this slide okay. So that treatment does not occur in a vacuum. So some additional recommendations and considerations include different levels of intervention at the structural, community, interpersonal, and individual level. So this can include public policies, access issues that I mentioned earlier, human rights issues, stigma, we've talked quite a bit about today already, community-based research that is needed, gender-based violence, addressing gender-based violence, relationship issues that may be unique to women along with trauma, and then individual targets, gender identity, sexual orientation, race and ethnicity factors, and pregnancy, along with any medical comorbidities or trauma. So just to summarize, substance use problems in women, women are using substances at increasing rates and approaching rates of use that we see in men, and experience unique health effects of substances that contribute to substance use problems, along with frequently experience concurrent mental health problems that need to be addressed. During pregnancy, cigarettes and alcohol are used most commonly, with the use of multiple substances being more the norm. And there are many barriers to accessing evidence-based care for women with substance use problems that we covered. And also adaptations that have been recommended, but that we also have not been the subject of a lot of research to date. All right, so that's everything that I wanted to cover. I am happy to answer any questions at this point, and also welcome feedback. So I'll maybe leave this up for a moment, but can also maybe even put the link to the survey in the chat, but so I can stop sharing and see people.
Thank you so much, Dr. Callio, for your presentation. Very, very informative. You provided a lot of foundational knowledge and then kind of moved into those interventions, which was really, really helpful. So we got a few questions, but I'll start off with Adrienne's. It says, are there any posters, brochures, or other literature around prenatal substance use that can be provided to local medical providers or child welfare officers to display or provide in their offices? We see these resources for tobacco, but not for alcohol and other drugs. And it seems like it could be helpful in kind of lifting the stigma that's associated with this, with women and substance use. So any thoughts there around posters and brochures that could be shared?
Yeah, our center has definitely developed a lot of different materials. Let me just, if you're interested, and this is actually a big part of our prevention work, is like getting out into the community and distributing this kind of information. But yes, Taylor, our wonderful public health educator, is here. And so she just put her contact info in the chat. If you have anything specific, because we have informational brochures about almost all substances, and some of them in multiple languages as well.
Perfect. And again, thank you so much, Taylor. We love when we can tackle things from all areas. So I'll move on to our next question. Let's talk about the role of community resources and support networks and how they play in the success of interventions of prenatal substance use and how these resources can be better utilized.
Yeah. I think specifically support services for substance use disorders. I think the they're actually so the 12-step programs that I mentioned earlier can be great and free of charge. I think that's another great part of them is that they're free. AA and NA in particular have many in-person meetings, which I think can be a great, many people are looking for that. And at the same time, they have quite a few virtual options as well to kind of increase access to care. But also I mentioned earlier the Smart Recovery, which is a skills-based program. So not everybody is drawn to the 12-step programs. I think there are pros and cons to all different kinds of community supports. Typically AA and NA is peer led and is there is some stigmatized language that is used. So you have to call yourself an addict. And so that is not always preferable to some people. So Smart Recovery is a great alternative. It is, like I mentioned, a skills focused program they have fewer in-person meetings, but they have lots and lots of virtual options. There are some other kind of lesser known virtual and alternatives to 12-step, but Smart Recovery is the one that I think is the most kind of extensive. They have workbooks and lots of materials that can be helpful.
Mhm. Yeah, thank you so much for bringing that resource to light. So on to our next question. How can healthcare professionals effectively address and reduce the stigma that's associated with prenatal substance use?
Jayla, sorry, could you repeat that? I was reading some of the chat and missed.
Oh, no problem, no problem. So the question reads, how can healthcare professionals effectively address and reduce the stigma that's associated with prenatal substance use?
Yeah, yeah. I mean, I think it's obviously tricky because we can't tell people necessarily what they need to be doing, but I think I mean, the best we can do is talk to maybe educate each other, stop, adjust our language so that we're not using the stigmatized language, and really talk when we're interacting with patients and individuals with substance use disorders. That we are not using that language and that we're really trying to talk about it in a way that fosters their not feeling like reducing the shame that they experience, and really trying to make it help people understand that this is a chronic brain disorder and also instill hope that there are things that can be done to help.
Yeah, thank you so much. That kind of bleeds into our next question, which talks about the different strategies in communication, right? When you're having these conversations. And it sounds like you're speaking a lot to not only like the education around the disease model of addiction, but also making sure our language isn't stigmatizing. So are there any other like effective communication strategies that you want to highlight that is helpful in kind of reducing the stigma?
Mm-hmm. Let's see, any other communication strategies? I mean, I think the other thing that I didn't really mention just now is that I think educating the family and involving the family is it can be a great way to reduce stigma because you're like, sometimes the messages they're getting are from their families, like, why don't you just stop this? You're causing so much harm, or you're damaging yourself. And so being able to involve the family, educate the family, and then give them information about how they can support the individual who has a substance use disorder in their recovery. So, for example, like if a family has substances in the home, like alcohol in the home, kind of helping them see that that's maybe not so helpful, and that the person shouldn't be expected to just kind of have willpower not to use those substances. So I think that can be a great way to reduce stigma through their kind of immediate community.
I am actually really excited that you brought that up. I didn't think of that, but being able to collect so many stories and connect to different like organizations throughout Georgia, we talk a lot about how like people recover in community, and you're really speaking to other people being able to advocate for their loved ones, help educate others, and also support them in different ways. So thank you so much for bringing that up. That is actually our last question. No more questions came through the Q&A, but I want to take some time not only to thank you, Dr. Callio, for all of the amazing information that you shared with us today, but to highlight again that if anyone has any questions, feel free to contact Taylor Neither, who shared her contact information in the chat. I'll also make sure it's included in our follow-up email. Also, please let us know how you enjoyed the webinar. Ashley's going to share our feedback link just so we know what was really, really helpful regarding our webinar series. So outside of that, thank you all so much for your time. And also Dr. Callio included her email as well. So we will see you all at the next webinar. Thank you all so much.
Thank you all.
Bye.